So I will show some pictures and audience can participate in this. So, very simple questions. What is the sign seen in OCT and which is suggestive of macular ischemia? I just told you. Okay, so this is the outer plexiform, outer nuclear, inner plexiform, inner nuclear layers cannot be traced in the OCT scan. So it is called disorganized retinal inner layers. This is a sign of ischemic maculopathy, and you can even avoid, that could be the cause for defective vision in spite of good response to treatment with anti-VEGF. So that is drill. So all of you should be able to diagnose this in OCT. Just take first of all, when you take an OCT picture, OCT test, please look at the black and white picture, not color picture. Okay, the green one will not give this much clarity. So it is very difficult to trace in a pseudo-colored picture. So look at the black and white picture and always see multiple layers. That is one advice. Don't look at the one printout and say, a lot of people are treating many diseases just with the printout. Just like our glaucoma persons are telling, don't treat based on one picture only. So you need a, so that is drill. So this is which condition? Erosion sign or flap sign. There is a, in the octa there is a small network, right? The right side. Yeah. Pointer. So the RP, there is erosion, and in front of that there is a subretinal hyperreflective area with fluid. So this is, as I told some time back, this is very characteristic of retinal angiomatous proliferans or type 3 MNV. Okay. So basically the retinal new vessels start from the retina, grow inside, and there is a discontinuation of the RP. So that is called, it is called erosion sign or flap sign. What is typical sign seen in SDOCT, which is characteristic feature of very simple questions. What is the typical sign seen in SDOCT, which is one of the characteristic feature of PCV? Is it serous PED, hemorrhagic PED, thumb-leg PED, RP undulation? So this is what I said. Okay. So TLP, thumb-leg PED, is very typical of polyp. Actually, when you see a thumb-leg PED, the upper part will have some hyperreflective area. Actually, the polyp will be in that area. One more thing that I want to tell is, usually polyp will not be alone. There will be a branching vascular network underneath. So when there is a PED and there is a double layer sign, under the double layer sign there will be network. Under the thumb shaped PED there will be polyp. So when you do angiography, you can easily correlate with that. So this is a typical sign of PCV. What is the possible cause of sub-RP area? This is what just I explained. What is this? Sub-RP, this is a thumb-shaped PED. Just under the RP, there are some hyperreflective area. What is this? Is it hemorrhage? It is not blocking, reduced backscattering is not there, so it is not. So is it outer retinal tubulation? No, I will show some other picture of outer retinal tubulation. Lipofuscin. So this is the neovascular complex or the polyp where it is there under the RP. So that is the hyperreflective area in the sub-RP area is in PCV is due to neovascular complex. Any comments or anybody in the panel you can contribute to this? Otherwise it will be a boring thing. Then yeah, anything. I am just showing a lot of pictures so that you can have some. So extra large PED, like it is not shirt size, XL sized PED. Where will you get? Again, everything extra large is in PED, in PCV. So huge plasmic epithelial detachment is very characteristic in PCV.
And will you call it as extra large?
That because it is not small. Something we have to tell now. I will get another question for you. By definition, what is extra large pigment epithelial detachment? So you can 550. Actually, this it is taken from some studies. This answer is B. Okay, why it is B, I don't know. Somebody has used it in. So basically, it is more than 500 to 1500 microns height. So it is a. This is not a typical hemorrhagic PED. It's due to a large size that you don't see anything under the choroid. So that is extra large PED. So what will be the feature of branching vascular network on SDOCT? How, just now I explained. This is a thumb-shaped PED and this is branching double layer sign. So double layer sign can be of two types, hyperreflective double layer sign or hyporeflective double layer sign. If it is hyperreflective double layer sign, it is typically seen in PCV and there will be a branching vascular network here. In hyporeflective double layer sign is usually seen in CSCR where this will be only fluid. Okay. So that is, so it is double layer sign and their BVN will be under this. What is this? What is this? You can see that this is the RP, it is going up and then suddenly it is coming down like this. And this area, there is increased backscattering. So there is no RP, that is why it is increased backscattering. And so this is the classic.
Yeah, the clue was in the previous slide actually. The last
it was there in the previous slide.
Yeah, yes.
Here, RIP was there? No. Clue was there. Okay. So this is a classic RP RIP, okay. So RP RIP, this area is denuded RP. So there is no RP here, you can see the choroid and sclera later. So this is folded to this area. So that is why this area is a classic RP RIP. Okay. So if you treat the patient and get a RP RIP, you have to continue treatment. It is only a event that has modified the outcome. That's otherwise the treatment there is no change. What is pointed below? What is this? What is this? Sorry. What is this? This is classical. It is seen in chronic cases. Okay, chronic MNV cases. So it is round and it is not like a typical intraretinal cystoid. It is hyporeflective foci, degenerated photoreceptor. Actually, it is the outer retinal tubulation where the ILM has retracted and become round. So this is called ORT. ORT can be in different layers. So this is outer retinal tubulation. It is a bad sign because the visual outcome and treatment outcome may not be very good. So this is ORT, outer retinal tubulation. What is shown here? This is spongiform edema, large cystoid edema, then serous macular detachment, and the taut hyaloid. What is this? This is the classification of OCT. Okay, OCT classification. And these are indications of anti-VEGF therapy, but usually in this condition, anti-VEGF will not work with taut hyaloid. A worse prognosis usually also is in cystoid, and this is the best prognosis. Others will have a little worse prognosis. So this is the answer is OCT classification of DME. Which of the following DME will be the most suitable for focal laser? Focal laser. Okay, lot of hard oxidates. Cystoid changes. Cystoid with serous macular detachment. And this is spongiform. It is said that when there are circinate, with hard oxidate, you laser the microaneurysms in the center, it will respond best. So that is what we give focal laser when there is a lot of hard oxidates with leaking microaneurysms in the center. So others can also, but this is just a point to take. Which one? This one, actually a lot of hard oxidates are there, no? You can do an angiogram and usually there will be large microaneurysms causing leakage. It is not like the diffuse macular edema, the hard oxidate may not be that much. It is not a rule, but I am just telling, yeah, Danya.
No, I think the only role of laser in DME is now to do a focal laser to a microaneurysm, because the rest of all is taken up by the anti-VEGF. And if it is a surgical indication, definitely it will go for a vitrectomy.
Yeah,
so
yeah.
Focal laser is one thing that is again staying back for management of DME.
In other words, grid laser is obsolete. Now we do laser only in center sparing, not in center not involving type of DME which circinates and there is a localized area of this thing with the microaneurysms in the center. So that is, again, this is already told, no? Double layer sign. This is hyperreflective double layer sign. What is the diagnosis here? You can see it's a large choroid, thick choroid, very high, with some pachyvessels. There is a serous detachment, there is a PED, there is fluid, there is hyperreflective fluid, hyperreflective area underneath. Is it blood, this hyperreflective? No, because if it is blood, you will not see anything underneath. Okay, so this is not blood. So what could this be? Pachychoroid disease, only 3-4 are there. One is CSR, one is BCV. So this is basically fibrin, in fact, where there is a PED. This thing is actually fibrin. I will show some other photos also. So this is a sign. What is this sign? There is an area of fibrin and there is a leak underneath, and this is RP rib, small micro rib with hyperreflective area underneath, and there is fluid. So this sign is called where there is a micro rib, central area, hyperreflective, and around that hyperreflective area. So this is what was called as vacuole sign. We reported in Bindu was there, no? We reported, Bindu reported in retina way back in 2013. So this is a vacuole sign. Because of the high flow of fluid, there will be some clear area just next to the RP, and then so this is another example of fibrin CSCR. A lot of fibrin is there, and that is being shown as hyperreflective area. Okay. So this is my anyone? There is a lesion here. This is an infrared picture. Okay. In infrared picture is just like a black and white picture of the retina. This you can see an area where there is something like this. So this is a. Is it a fluid? There is no fluid because there is no retinal edema. It's just a space, potential space sort of thing, corresponding to this angiogram and this. So this is basically what is called, it's a congenital anomaly, just like a coloboma. It is what is called a torpedo retinopathy. Okay, torpedo. So some people have mistaken it for choroiditis, healed choroiditis patch and all. So the clue is there is no retinal thinning or thickening. So that is why it is usually seen temporal to the fovea. Biju Raju has reported double torpedo, more than one torpedo in these cases. This is another case. Anyone? Diagnosis? What is this? Anyone? Indian Journal we have reported in 7-8 years back. It is called focal choroidal excavation, which is it is seen in some of the pachychoroid disease. It is of two types. One is conforming and one is non-conforming. Conforming is there is no gap actually here. The retinal tissue will be there. Non-conforming will be, there will be some gap here. So some people mistake it as a fluid and treat. Actually there is no need of treatment. This is seen, is called focal choroidal excavation. It is seen in many disease conditions, CSR, PCV, some of the CNVM. Post-treatment, conforming can become non-conforming, this sort of. It is not seen in VKH, okay, this is just a, so this is focal choroidal excavation. What is this? This is a 14-year-old child, don't say that exactly, retinoschisis. So it is not a cystoid macular edema, the structure itself is different, it is schisis. It is schisis. You have to examine the periphery and see whether there are associated features. What is this? Anyone? Dome-shaped macula. The important thing is, here it is a vertical scan. Just look at the scan, where it is going. This and this are all horizontal scans. You will get a large dome-like elevation with something like a fluid. But the vertical scan is flat. That is the clue. You have to do horizontal and vertical scan. So you will get a, that's a classic dome-shaped macula. I have mistaken it for CSR and did angiogram. Angiogram will show some basic staining in that area, which I even treated with laser without any effect. Then only we came to know about this entity. So it is called a dome-shaped macula. This is classic Mactel, I don't have to tell you. What is the sign here? This inner retinal layers are just collapsing into the floor. So it is called collapse sign, okay. So this was also described many years back. Ramiz Hussain had published it in Indian Journal. So this is Mactel. We have around 10 articles published on Mactel. Today I have put one in KSOS official group, latest one published for a new terminology of Mactel in the prestigious journal I, published from Kiran Chandran. So you can go through that, what is the new terminologies in Mactel. I have put in the KSOS official group. Yeah. Then this one, yesterday Dr. George Manet was explaining. So this is what is called multi-layered PED, and you can get cholesterol crystals inside. Pre-choroidal cleft is there. In front of the choroid there is a pre-choroidal cleft, and sometimes you can call it a triple layer sign. There is a cleft underneath this, and then choroidal capillary neovascular complex. So it is a triple layer sign, you can call it. It is a multi-layer PED, which is seen in more or less inactive neovascular AMD after many treatments. So that is, and what is this? Again, you may mistake it for CSR or any other disease, but you can see that this area inside, and vision is extremely good, 6.9 or 6.5, 6.9 or 6.12. So this is classic OCT finding in a Best disease. Okay. So I almost through. This is actually yesterday, I think, yeah, I have shown it somewhere else also. Large yellow area in the center, and there is no macular edema, in fact. Unlike a CNVM, there is no IRF or subretinal fluid, and fundus autofluorescence shows hyper-autofluorescent area. This is a classic adult onset foveal vitelliform dystrophy. Vision will be very good, 6.9 or 6.12. So that is a clue. And if you want to really confirm, don't do a dye angiogram. It will cause some staining. It is very difficult. But you can do an octa, which may not show any network in that. Okay, this is classic diagnosis. Sawtooth appearance. Choroid is not seen at all. And disc edema. And so this is classic VKH. And I have one more last this thing. This is inflammatory cause. There is a large patch, inflammatory, sudden loss of vision, there is irregular RPE. It is called acute idiopathic maculopathy, and there is the classic finding is there is retinal edema with loss of RPE, pseudopod-like extension and loss of RPE. So this is but compared to that, this is pigment epitheliitis, where there is a defect in the RPE, which also gradually recovers. So these are some of the examples of acute macular, UAIM and pigment epitheliopathy. There are some differences. I am not going to discuss the details. Time is over. Thank you very much.